The PSA may seem like a simple test, but it seems that what happens after the test isn't so straightforward. So as GPs, we order a PSA, the result comes back a bit abnormal, we send them off to you guys, the urologists. What happens then?
Then we'll say to the patient there is a whatever risk, depending on what the level of the PSA is, that you might have prostate cancer. And we'll say there are lots of other causes for the PSA to go up, like just benign enlargement of the prostate that happens in men as they age, or an infection in the prostate. Well, we can't be sure whether you've got cancer or not, and the only way to find out will be to put a needle into your prostate through your back passage and take some samples to see whether we can find any cancer or not.
What does a negative result, for example, mean on those biopsies? What does it mean for the patient?
So if we have a negative biopsy, that means we didn't find cancer, is pretty obvious. The problem with that is that we can't say to the man, you don't have cancer. All we can say is we didn't find any cancer. It's still possible that we might have missed the cancer. So a positive result shows that there are cancer cells in the prostate. And the biopsy actually tells us a little more than that. It'll tell us the nature of the cancer to some extent. That is, how aggressive or non-aggressive it looks to the pathologist. If we look at a whole spectrum of men and a whole spectrum of cancers, I would say at one end, 10% are feral, really nasty, questionable whether you can actually cure them anyway because it's so nasty. Of course, you can cure them if you find them really, really early. 30% who are aggressive will definitely get benefit from the surgery and are likely to be cured if they're found early enough. And that, of course, leaves 60% at the other end. And these are what we consider to be low-grade cancers. And it's those that cause us the most confusion and the most concern in many ways, because there's lots of evidence that maybe a lot of them aren't going to do anything. A lot of them may turn out to be those men who had a few cancer cells in their prostate and who are going to die of something else 20 or 30 years later.
So what do we do about the 60% who fall into that more uncertain category?
They're first of all confronted with the diagnosis of cancer. And you know, when you hear the word cancer, you're just waiting for the next C word. You don't actually hear most of the stuff. It goes right over the top of your head. You're waiting for the cure word. And of course, they can easily be cured, if you like, by being offered some treatment, because the chances are they're not going to die of their cancer anyway. But we know that many of these men, for a whole variety of reasons, are either offered or want to have some surgery and are offered radical prostatectomy. And that has caused such a lot of concern among the people who are saying we're overdiagnosing all these men, that the chances they'll be impotent is about 8 out of 10, and the chances they'll be totally incontinent is maybe 5% or 1 in 20, and a lot of those men will also have some dribbling incontinence.
But is this really a problem of over-testing or one of over-treatment? If we manage to reduce the number of men having surgery and experiencing those side effects, could that help?
In theory, yes. But in practice, once you've committed yourself to doing the test and discovering the disease, you're pretty much going down that pathway. If you're going to do the test, you need to think about what you're going to do as a consequence of it. If you're going to do the test, and if it's positive, not proceed, then you probably shouldn't have done the test.